So look at the name of this very important and notable primary immunodeficiency disorder, X-linked Agammaglobulinemia. This tells you that this disorder is mostly X-linked inherited, X-linked recessive disorder, and the main problem is absence of immunoglobulin in the blood. A means absence, gamma globulin means immunoglobulin, and anemia means in the blood. Like hyperglycemia means high blood sugar in the blood. Ketonemia means ketone bodies in the blood. Similarly, A means absence, gamma globulin means immunoglobulin, and anemia means in the blood. That means absence of immunoglobulin in the blood. That is the main problem of this X-linked recessive disorder. That's why it is also called X-linked Agammaglobulinemia. It is also known as Bruton's Agammaglobulinemia because the problem is mutation or deletion in the Bruton tyrosine kinase gene. So that's why the disease is also called Bruton's Agammaglobulinemia, because the Bruton tyrosine kinase mutation results in absence of immunoglobulin in the blood. Now, this disorder is typically occurs after 6 months, because till then, up to at least 3 to 6 months, the mother's immunoglobulins are there in the baby's blood. So till then, the baby is protected from lacking the production of the immunoglobulin. But the problem typically would occur, the severe features only occur after 6 months. Because then the baby would start to feel the pinch, because he, mostly because this is the male child's X-linked recessive disorder, they cannot produce the immunoglobulins. Now, what is the main problem in the X-linked Agammaglobulinemia? The main problem is that B cells, they mature stage by stage, step by step in the bone marrow. That maturation cannot occur because what happens, the maturation of the pre-B cell to the mature B cell, that get arrested because this mutation is occurring. This signal is required for their maturation. As the maturation arrest occurs, so mature B cells cannot form in the bone marrow of the patient. So that's why the distinguishing feature of this disease is this, that if you check the peripheral blood, you will be not getting any mature B cells, which can be confirmed by doing a flow cytometry, that if you check that there's a absence or near total absence of mature B cells manifesting CD19 or CD20 on the peripheral blood. So B lymphocytes are almost absent or not seen, but T lymphocytes are okay. T lymphocytes are seen in normal in number in the function. Sometimes they can be increased also. This is a distinguishing feature of this disorder, X-linked Agammaglobulinemia, with severe combined immunodeficiency disorder, SCID. Because in SCID, the main problem would be T cell, their level would be decreased or absent. But in this disorder, T cell would not be decreased. It can be normal, even can be high also. And obviously, as mature B cells are not produced in this disorder, X-linked Agammaglobulinemia, there will be no presence of plasma cells also in the tissue. So plasma cells would also be absent in this disorder. And another very distinguishing feature is that immunoglobulin level, which would be decreased, there would be pan-hypogammaglobulinemia, or pan, total absence of all classes of immunoglobulin. That means it's not selectively one class of immunoglobulin like IgA which is deficient. It's not like that in IgA deficiency. All classes of immunoglobulin, GMED, they would be low or absent in this patient. So if you get a patient which is peripheral blood, if you get a male child who is typically presenting after 6 months, not immediately after birth, but after 6 months, is presenting with recurrent infection, recurrent sinopulmonary infections, recurrent infections of the ear, recurrent infection of the respiratory tract, lungs like pneumonia, and this is occurring due to encapsulated bacteria, typically after 6 months. And this is happening typically in a male child, and the repeated infections are occurring, which are mostly, many times can be resistant to multiple courses of the antibiotics would be required. This case, this recurrent infection which is occurring, you start to think about this disorder, that is the X-linked Agammaglobulinemia. And diagnostically, I told you these features are important. There is a total absence of the mature B cells, near total absence of the mature B cells in the peripheral blood. There would be T cells, their level would be normal, sometimes even can be increased. And immunoglobulin, irrespective of all classes, their level, all classes of immunoglobulin, their level would be low. Plasma cells would be absent in the tissues. Lymphoid tissues like tonsils, they would be absent in the patient. If all these features are seen together, this is quite characteristic of X-linked Agammaglobulinemia or Bruton's Agammaglobulinemia. Same thing. And obviously, as the main problem in this patient is absence of immunoglobulin in the blood, you need to supplement that immunoglobulin. You need to provide the immunoglobulin to protect the child from the recurrent encapsulated bacterial infection, to prevent those infections. This is the key policy in the management. So that's all. That there's a few key things that you need to know about the X-linked Agammaglobulinemia. Thank you so much.